أنا طلبت منه هو تعريف عن حضرته، فكان it's very brief. دائما صراحة أنا بخجل مع الدكتور ياسر أو مع الدكتور بروف خورشيد وقت اللي بطلب منهم تعريف، اللي أحط اللي بدك إياه أنا خلاص it's okay whatsoever you'll add. فهي sent just very brief that he is a professor of pediatrics University of Manitoba, and the title will be Protective Lung Strategies by Conventional Mechanical Ventilation. أعتقد ممكن معظم الناس اللي حضروا المؤتمرات في السعودية تقريبا لا يخلو مؤتمر من مساهمات دكتور ياسر القيمة. وصراحة نحن شفنا كتير مساهمات له سواء في الميكانيكال فنتريشن أو الأخوة اللي حضروا الألترا ساوند والبوكس نيو الابليكيشن الهيموداينامكس الريسيرش اللي عم ينشروا الأشياء البيزك والأنيمال لاب. صراحة يعني سعداء جدا دكتور ياسر بيكون شخص مثل حضرتك معنا اليوم بيقدم محاضرة كبداية في المحاضرات للهيئة السعودية. حياكم الله جميعا وأهلا وسهلا.
أهلا وسهلا بكم جميعا ومرحب دكتور عدان it's really a pleasure to be with you today. Probably I have met some of you in the previous events in Jeddah or Riyadh. It's my pleasure to be with you at any time. My time is not limited, so I have the presentation might take probably about 40-45 minutes, and I have no limits for questions. So whatever question you have, feel free to ask. I know that's a little bit late, but for me, I have no problem. So I already, this morning, I'm off service. I was covering the last 7 days. So today for me is just administration and teaching. So I will start my presentation. And again, it was really wonderful start today with the questions and your answer. Actually, most of you answered most of the questions correct. There's some maybe confusions about some concepts. And based on my previous education, either here or other places worldwide, I collected actually all of the confusions, and I am going to focus on the misconceptions in this presentation. So we're not talking about mechanical ventilation just as a technique, just connect the baby to mechanical ventilation. We're talking about how to protect the lung using the mechanical ventilation. And I will let you know why we need to protect the lung. So I have nothing to disclose in this presentation. And as you know, we are in the era different from evidence-based medicine. Now we are in the era of precision-based medicine. For almost 30 years, as you know, evidence-based medicine started. Yeah, just mute yourself if you don't mind. The evidence-based medicine started at McMaster University, early 1990s. And since that time, a lot of research done, a lot of higher level of research, billions of dollars on research related to neonatal care or prenatal care or maternal care. And whatever completed in 30 years, just highlighted in this slide. So what we know exactly from evidence and not a controversy, because most of the things that we do, there is still question mark or controversy, but the things that we are sure about, we have 4 things good for outcomes: breastfeeding, skin to skin, delayed cord clamping, and surfactant. So we are kind of liberal to apply these interventions. We'll talk about surfactant because it is related to our topic today. So for natural, I mean natural, it is gift from God. So even surfactant, it is manufactured based on the natural surfactant. And for interventions that we do, we know for sure they are good for outcomes, including antenatal steroids. So we don't think too much about giving antenatal to any woman in labor with premature labor, regardless what is the underlying cause. And then we are not really hesitant to give caffeine for premature babies for at least a certain period of time after birth. And then non-invasive ventilation in general, or CPAP. We know that CPAP is good for outcome, so we can leave babies on CPAP until they are able to breathe without support, without any hesitation about extend the period of CPAP. And cooling for HIE, that's outside the premature management, but we know that any infant with HIE, moderate or severe, will benefit from cooling. And then we have 4 things are bad for outcomes, including our topic for today, invasive ventilation. So that's why the main concept that we have to focus on today, once you put the baby on mechanical ventilation, invasive ventilation, we have to have a very clear plan when we should get this infant out of ventilation as soon as possible. So when we do round every day together with the respiratory therapist and the nurses and our team, our fellows, for any infant with mechanical ventilation, we should discuss the main concept, how we get this infant soon uh, extubated to non-invasive ventilation. Antibiotics, even one single dose of antibiotic is enough to shut down all of the microbiome in the body, including the microbiota in the respiratory tract, which might induce more susceptibility to chest infections and VAP. So be cautious about using antibiotics. It's not a gift. It is a medication that might carry a lot of side effects. Cardiovascular medications, and for almost 10 years now, we are relying on hemodynamics management, a very specific management based on the underlying physiology. We are now out of era of using dopamine and dobutamine, epinephrine for everyone without understanding what's going on. So we are out that era for, I mean, in North America for almost 10 years now. And we were using a specific medication according to the specific underlying cause of shock or hypotension. And then keeping the baby MPO without a reason, that's really bad because that might induce villi atrophy and might affect the enzymes and hormones for digestion. So let us move on. And before applying any intervention, ask what is the ultimate goal or benefit of your intervention. And the intervention including mechanical ventilation. So in neonatal intensive care unit or any unit in medicine, adult intensive care or ward or anywhere in the hospital, we have 2 things that we are focusing on. And specifically for NICU, there is 2 things. The 2 things that are the main aim of our round every day. So we do 2 main things or 2 main uh, goals from assessment of vital signs. We have the infant on monitor and we assess all of the vital signs, clinical examination. Exactly, we are targeting to maintain and promote positive metabolic rate and promote growth with 0 water balance. I mean, the water balance in going in should be equal to going out with the positive growth. And then maintain tissue need for oxygen. So the oxygen delivery to the tissue should be maintained. So we assess a pulse oximetry for oxygen histograms, blood pressure. We assess if you have near-field spectroscopy for oxygen consumption, temperature, everything, and even blood gases, everything related to or aiming to be sure that the tissue is getting enough oxygen. So what we do in the unit every day, our work as a team, just be sure that the body is getting enough oxygen and the infant is growing in a positive way. And then the outcome at the end to discharge home without complications. And then interventions, the interventions provide either one or both with minimal side effects. So we have 2 main goals. Any intervention that you do, mechanical ventilation or anything we do in the unit, should have 1 or 2, number 1 or number 2 or both. If you are not getting any one of them, then you are just applying intervention for complications, not for benefits. So we ventilate based on a nice concept, love, and we selected this romantic uh, um, acronym for ventilation just to attract people to follow it. It is laws of ventilatory efficiency, and it is include simply develop a specific strategy for a specific pathophysiology. So when you select a strategy for mechanical ventilation, don't assume that we have a scheme in your mind about tidal volume is 4 or 5 and select PEEP of 7 and I time of 0.1 for everyone. That doesn't work in medicine. So we have to assess the underlying pathophysiology, and you have to consider the strategy based on that. And the strategy means it is invasive or non-invasive, synchronized or non-synchronized, and also the parameters that you are going to apply. So pick the ventilator that can deliver the specific strategy. I mean that it is non-invasive, either synchronized or non-synchronized. And I mean non-invasive, not only CPAP, I mean the non-invasive positive pressure ventilation. And we are using now nasal high frequency ventilation, non-invasive, or NIV-NAVA. I'm not sure if you have it or not, but if you have it, that's the true synchronized mode of non-invasive ventilation that's available in the market now. So select the ventilator that can deliver a specific strategy for the pathophysiology. And then it changes the ventilator strategy as the pathophysiology change. So the infant, premature infant, or even term infant with RDS during the first few days of life, this is different from infant with evolving chronic lung disease. And we'll see how to change that when we go on in the presentation. Different from infant with meconium aspiration, infant with, for example, healthy lung, but ventilated for non-respiratory reason, for example, post OR, mechanical ventilation, with assumed healthy lung. As soon as you intubate a baby, work towards an appropriate extubation. So your main mission, you as a neonatologist or a team working in NICU, once you get the tube in, I'm talking specifically about premature infant, every day on mechanical ventilation increase the likelihood of having poor neurodevelopmental delay by 1%. So can you imagine every day counts being on mechanical ventilation? Not only may damage the lung, may block all alveolization, may induce VAB that actually will affect the brain development. So that's your responsibility. Every day you keep on mechanical ventilation for no reason, it is bad for everything, bad for the brain, bad for other organs, and this is your responsibility. So how should we ventilate? Goals of assisted ventilation, summarized as to achieve uniform lung inflation. That's intuitive, very straightforward. You are ventilating to achieve lung inflation, and lung inflation, as we explain later, is two things: the functional residual capacity and the ventilation during inspiration. And then minimize over and under inflation. And we will go over how to achieve that simply. And then minimize FiO2. The most toxic medication that we ever use in NICU is oxygen. It's more toxic than anything else. Toxic not only to the lung, to the neuronal cells, to the retina, to everything in our body. So giving oxygen, extra oxygen, is going to cause significant harm. That's why when we have infant requiring very high oxygen suddenly, for example, I'll give you the extreme 100%, it means that it is a disaster. I cannot go home when I have infant on 100% oxygen in the unit. I have to work on to get this infant on less FiO2, because 100% oxygen, as we are leaving infant with shock dying. Early appropriate extubation. Again and again, early extubation, once you have the infant fulfilling the criteria for extubation that we will describe soon in this presentation. So how should we ventilate? Or just what we described before in the previous slide, I will show you that on this graph. So assume that we have two red zones here. We have the lower red zone, which is atelectotrauma zone or atelectasis, and the upper red zone that you need to avoid as well, which is overdistension or volutrauma zone. And we are working in two things to control, basically, the PEEP and tidal volume. So if you have infant with the worst example for sure, and that's very rare to happen, when you have infant with very low PEEP, and I'm talking about low PEEP, there's still people applying PEEP of 5 or PEEP of 6 for infant who is mechanical ventilated, which is not really appropriate. This is very low. In literature, we found that whatever PEEP you are applying, whatever reaching the lung is almost 50% of that. So usually when you reach infant on mechanical ventilation on PEEP of minimum 7, 8, or 9, we extubate. Even we extubate from 10 on PEEP of 10. Because if we decrease lower, then you have the infant at risk of atelectasis trauma. And then the same for volume. When you give too much volume, and we have description what would be the appropriate volume. For example, you give volume of 10 on infant who just born, that's too much. That will induce volume trauma. What's the case if you apply too much PEEP? And too much PEEP inappropriate, and too much PEEP, there is no specific number. What the PEEP is high. It can be 15, and the infant requiring 15. But when your infant is developing over distension, as documented on the graphs and documented on the X-ray, for example, then it is high PEEP. Then you have to reduce it. Or the most sensitive marker to reflect high PEEP is to assess heart filling. If you do echocardiography and you see the venous return reduced, there's definitely high PEEP reducing the venous return. Even if you have normal tidal volume, but in this example, you are inducing volume trauma. And then only atelectasis trauma when you have low PEEP, but even when you have normal tidal volume. And then what you are targeting now, the optimum ventilation, optimum PEEP, and optimum PEEP, regardless the number, PEEP of 7, 8, 9, 15, 20, it is a PEEP that recruit to functional residual capacity. We have seen like the highest number in my experience, I think was probably 24 PEEP. Might be a terrible number, horrible number for you, but we have reached that in severe bad chronic lung disease, which is rare. Frequently, we have between 15 to 20 in some bad chronic lung disease, but that was extreme case. It might be one in my experience. So we have a PEEP that is recruiting the lung to the functional residual capacity, which is our marker now. We have to recruit the lung to FRC and the tidal volume appropriate for enough ventilation, normal ventilation, regardless how much tidal volume, but it is a tidal volume that maintain normal ventilation. So how should we ventilate? We are talking about the safe window. So you need to use an adequate PEEP to maintain FRC, again, functional residual capacity, and avoid atelectasis trauma, and use adequate tidal volume to avoid volume trauma, simply. And again, it's not about the number. There is no, the number can be 5 high for an infant and can be low for another infant as a tidal volume. So you need to be sure that the infant's getting the volume that maintaining the minute ventilation at the end. So just if you are at the early training stage of fellowship, and you need to understand the concept of mechanical ventilation, it is as simple as you see in this graph. So the working principles of conventional ventilators is you are applying flow generator, just a flow generator. It is a little bit complex in mechanical ventilation, but that was the design for the early or the first mechanical ventilator a long time ago. So just a flow generator applying a consistent or continuous flow. And this flow, as a continuous flow, is applied to the lung. And there is expiratory valve here, which closes in a specific time. And this time is an expiratory time to allow the air goes into the lung and then relieve or release the valve as during expiration to let the air goes out, because it is continuous flow in one direction. So it is as simple as that. So what we need to know, how much flow we are applying, and through this flow, the machine can adjust or calibrate a tidal volume and the pressure. And we have the time cycle valve here. So we have the pressure limited, and also we have the volume limited. So as we'll explain later, what we are using in NICU is pressure limited. It can be hybrid with the volume, but we are not using volume limited. It is mainly for adults. Now we'll talk about types of or type of conventional ventilators. So we have the type of control, either pressure or volume, but can be combined or hybrid. The one that we are using in most of our units, and I assume they are using this model the same as our machine, it is pressure, but hybrid with volume. And we'll explain how it works. And then again, we are focusing on the pressure limiter. Just ignore the volume for now because we are not using it. We are using the hybrid mode, but just focus now on the time cycle limited by pressure. Simply, it is PIP predetermined. So we predetermine PIP of 20, 25, or 30 without volume. We're not talking about hybrid volume now. And then the mean air pressure is calculated based on your I time preset, B preset. You preset that on the ventilator yourself, and PIP. So the mean air pressure is the curve or the area under the curve for the I time, PEEP as a baseline, and PIP. And PIP maintained during the whole inspiratory time. Just please focus with me in this point. Why we are not using the volume limited ventilation in neonates. As I will show in the graph, neonates, they don't have enough capacity to create, especially premature infants, I time. So we don't allow the I time to be determined by the patient. In premature infant, while breathing through a small tube, this is very tough to happen. Tidal volume, it is varies according to the lung compliance with the minute ventilation. So in the pressure limited ventilation, the ventilation that we are using in units, now we can see that the pressure is maintained during the entire inspiratory time, which is not the case in volume limited ventilation. And we have two reasons why you are not using volume limited ventilation in units. The volume that you are using in units is very small volume compared to 500 ml per breath in adult. And again, the capacity of the adult to create I time is good, so can reach the volume at the end of the cycle here, as you can see, gradually. But in units, during the small I time, the pressure is maintained and plateau during the entire period of the inspiration, which is not the case in volume limited. That's why we prefer to use pressure limited in units. We have the pressure maintained plateau during the entire inspiratory time. And one more thing, the flow is variable according to the compliance. It's not the case in volume limited. It is fixed volume, regardless of the compliance. We have in units very variable compliance with RDS after surfactant or chronic lung disease over time of lung maturation. That's not the case in adult. So we have fixed volume delivered during the inspiratory time, or fixed flow delivering specific volume, but it's not the case here. It's a little bit variable according to the lung compliance. So limited by pressure advantages, maintain established PIP during the whole inspiration. Sinusoidal flow curve is not rectangular, it is sinusoidal, and you may have sudden change in tidal volume with a change of compliance. And for this reason, we are using hybrid mode with tidal volume, because sudden change in compliance might significantly change tidal volume. Make sense? So for these reasons, because of significant change in compliance, we are using hybrid mode. And let me explain what hybrid mode means. So we have higher risk of value trauma if you are using just pressure limited ventilation without hybrid mode, and higher risk of hypoventilation with alveolar over distension, which is the opposite. So hybrid mode, let us now focus on the mode that we are using. Regardless, we are using servo, which is one of the new ventilators now we are using with NAVA in a lot of centers in North America, or if you're still using Draeger 500 or whatever ventilator that you are using with the hybrid mode, combined pressure and volume. So this is not a volume limited ventilation. That's one of the misconceptions to a lot of our colleagues. That's not a volume limited. That's hybrid mode. It is a pressure limited and with the volume hybrid that might deliver as a preset volume but variable pressure. And let us understand that more. So it is pressure ventilators with continuous tidal volume monitoring. And they give peak pressure or inspiratory time automatically adjusted to ensure predetermined volume. So we predetermine inspiratory time 0.35 or 0.4, or in cardiac lung disease even 0.5 or more, according to whatever you need to deliver the volume and give enough time for expiration as well. So let us please focus with me in this slide to explain what is the hybrid mode, how it works, which is a combined pressure and volume. It is basically pressure limited, but hybrid with volume. So now assume that we have a preset volume, or for example, 5 ml per kg, and the machine will deliver the pressure needed. It could be 15, could be 20, based on the compliance to deliver this preset volume. Assume that the tidal volume became less than the preset. So how the machine detect that? Through the expiratory limb, there is a flow sensor that can detect and estimate the expired tidal volume and can synchronize that with the machine to ask the machine for next breathing, please increase the pressure because the tidal volume now is less. So increase the pressure so the next breathing will be reaching the preset, which is 5 again instead of 4. So now you have higher pressure needed because the compliance decreased. What about if the next pressure will be the same, but what about if the tidal volume in a different breath is exceeding the preset? Now you have higher tidal volume. I don't need that high. So that will synchronize the machine, ask the machine, please deliver less pressure to avoid volutrauma. So the pressure will be back to the 5 ml, which is a preset. So you guys, please set on the machine 5 or 6. So the machine all the time trying to adjust the pressure up and down to match that preset volume. I hope that makes sense to everyone. Again, this graph will explain the same concept. So we have the measured tidal volume. On the machine, you have 2 numbers for the volume. You have your preset tidal volume, which is fixed number 5, 6, or whatever number. And then you have the measured tidal volume. The machine measures from the expiratory limb, and that can be variable. So based on the measured tidal volume compared to the set tidal volume, if it is less, the machine will apply more pressure. If it is more, the machine will apply less pressure to get the measured almost equal to the preset tidal volume. If it is exactly equal, then you will apply the same PIP. So based on how much pressure needed, I can get an idea about the lung compliance. If the machine is delivering too much PIP to deliver the preset volume, it means that the compliance is poor. If the machine is delivering low PIP, it means that the compliance is getting better. And then I may target my extubation. So again, we discussed the 3 modes of pressure and volume, which we are not using. We are using the hybrid mode. And for hybrid mode, you should have a ventilator with a flow sensor that can detect the expired tidal volume. And then based on the type of breathing, so we are already now finished with the control, the 3 main types, and we focused on the hybrid mode that we are using in most of in ICUs. Now the type of breathing, either synchronized or non-synchronized. Very, very important to understand this point. And for synchronized, non-synchronized, that we have intermittent mandatory ventilation we are not using anymore with fixed flow and fixed I time. That's probably more than 30 years ago type of ventilation. Now we are using synchronized triggered by patient. So either SIMV, which we started to use now more often in severe chronic lung disease, it was high tidal volume, and I will explain the protocol. And then we have AC, the most common mode used, assisted control, and BSV, which is patient synchronized ventilation. Patient synchronized, which is synchronized to the point that the I time is variable. So the patient decides for I time, and if the flow is variable. So it is a true synchronization, but we are not using in premature infant anymore because the limited ability of the premature infant to decide for his I time. We are using either AC or SIMV in chronic lung disease. So the IMV, SIMV, AC, it is cycled by time because the I time is fixed. The inspiratory time is fixed for all of them. But BSV is cycled by flow because the I time is variable. The patients themselves decide for the I time. So let us go one by one. So IMV, which is the first mode used ever. And for each mode, we are going to discuss what's the control of breathing, initiation of breathing, termination of breathing, is it synchronized or not, and support, is it controlled, assisted, or synchronized. So now we have the patient breathes, which is negative. That's normal breathes, not the ventilator breathes. We have negative, which is inspiration, and expiration is positive. So always an inspiration, normal inspiration without mechanical ventilation is negative below the curve, and expiration is positive. So the IMV is working totally different away from what is the patient is taking. That's why you cannot apply IMV without sedation or without muscle relaxant. And again, we are not using that anymore. There is no any kind of synchronization in this mode. So the control of breathing by pressure, synchronization, there is no any synchronization. It is time cycled, fixed time, fixed flow, and fixed cycling between inspiration and expiration. It is totally controlled by the machine. There is no any control from the patient. Now let us talk about the next one, SIMV. So SIMV, now we have the normal breaths again from the patient, positive and negative, negative for inspiration, positive for expiration. And the initiation of the breathing is through the machine. So it is synchronized. Once the patient starts to take the inspiration, the machine will synchronize and start the breathing. But the end of the breathing is not synchronized. So the patient is obligated to respond to the I time from a machine. So it is synchronized only at the beginning, but not for the termination. So control of breathing by pressure, it is synchronized. So that once the infant start to breathe, to take, it is synchronized, time cycled, and fixed flow, and I time is fixed, and it is totally controlled. Now, you can notice that only the number of breaths that I decide on the machine supported, but if the infant breathes in between, is not unsupported. So if I apply 25 rate on the machine, but the patient is taking 50, only 25 supported and 25 is unsupported, which is different from AC assisted control. It is controlled, assisted by the patient, and controlled, and mean assisted by that every single breath by the patient is assisted. So there is nothing in between. So the infant starts to breathe, and the machine is giving the breathing, the predetermined the pressure and I time. And again, the termination is by the machine. So the termination is not synchronized because the I time is fixed. So the I time is fixed, and the expiration is, in this case, is passive. So the infant exhale after the preset I time. But again, the total, the expiratory time is controlled by the rate and the I time. So if you give insufficient time for expiration, the infant will be at risk of ear trapping. So you have to be sure that you are applying I time and the rate is still enough to get expiratory time enough for exhale all of the air out without air trapping. And I will show you how to detect that on the flow graph. So control of breathing, it is by pressure. It is synchronized at the beginning, but not synchronized at termination. It is time cycled with variable flow, and I time is fixed. It is assisted. Every single breath is assisted by the machine. That's why it is AC assisted control. It is assisted. The patient is every single breath is started by the patient and assisted by the machine and totally controlled by the machine, which is different from BSV. So BSV, now we can see the patient breathes with variable I time. So the infant might take sigh, might breathe like really long I time and long expiration, and can be small breathing, and the machine is following exactly. So it is pressure controlled, synchronized initiation. The I time is variable according to the patient needs. So the patient can terminate the breathing at any time according to his own I time. Again, this is not a really good mode for preterm infant because they have very small I time and they get tired very easily while they are breathing through very narrow tube. So they cannot maintain the I time through a tube size 2.5 or 3 all the time. We have used this mode to check that the infant is breathing synchronized mode and breathing spontaneously on low rate before extubation, and we stopped doing that for almost 3-4 years. We are not doing that anymore. So we're not using BSV in premature infants anymore. It can be a good mode for term infant with healthy lung. So now let us see the 3 main categories: IMV, AC, and BSV. So IMV, it is controlled the breath. Ventilator does all of the work. So you can see now someone is hanging on and trying to pull, like cannot pull. So the machine is pulling him completely. He does not perform any kind of work. But in assisted control, the patient just initiate the breathing and the machine does most of the work. So just initiation. Once the machine detects that the patient start to breathe, then the machine continue to do the rest of the work. BSV, the machine support the breathes and the patient does most of the work. As you can see here, the patient is strong enough to pull his body up. So the machine is not pulling him. He is pulling himself. And that's why you need strong lung. You need someone with healthy lung, like post-operative cases, for example, and or someone ventilated for airway issue, very tight airway, not and healthy lung. So we finished the first part of our presentation. Now we'll talk about another part related to graph loops that you can judge the adequacy of ventilation related to the adequate PEEP, compliance, adequate I time, and expiratory time. The first and the most important one about the pressure volume curve. And the pressure volume curve is available on the monitor or almost all of the modern ventilators. So we have the y-axis here is the volume, and x-axis you have the pressure. So you need to be sure that most of the breath is in the middle here. So when the infant requires too much pressure to start the breathing, so here is the PEEP level, and here is the beginning of the breathing. So if the patient requires too much time to initiate the breathing, means the compliance is poor. And the other part that you need to focus on, the top part, if you have a PEEP part of the curve, it means that you have over distension. You don't have to measure to do anything. The machine will give you a number here, which is called C20 over C dynamic. So the last 20% of the curve should be consistent and equal to the curve of the entire loop. So if you have the line here consistent with the entire loop and another curve with the last 20%, they should be identical, should be equal to 1 or exceeding 1. If you have the number less than 0.8, this is consistent with over distension. And you can see that simply on the machine. So don't forget to look at C20 over C dynamic. And you have the number less than 0.8. This is a sign of over distension of the lung. Again, when you see side-lying appearance of the curve here, it means that you have poor compliance. So the infant required long time to initiate the breathing. And you need actually to move the curve, to move the PEEP. So the PEEP, instead of here, very low, you have to move it here, as you can see here. So the PEEP here, instead of 5 or 6, you have it at maybe 7 or 8, is enough to recruit the lung. So this is more designed to evaluate the FRC. So you have a good functional residual capacity, the lung is inflated at the end of inspiration. The end of expiration. The lung is inflated and kept inflated even when the infant exhale at the end. Another application of the pressure volume curve, if you see this 8 shape loop here with narrow, very narrow loop, it is a sign of air hunger. So here at the end, the infant trying to take a spontaneous breath. That's why you see it like a curve was inverted at the top here. The infant is unsatisfied with the machine delivering the breathing. So it's trying to maintain or take another spontaneous breath at the end. So if you see figure 8 was very narrow loop here, it is a sign of air hunger. What does that mean? You mean you need either to extubate the infant or increase the tidal volume. So we call it inadequate hysteresis of the loop or flow starvation. Many either flow starvation, inadequate hysteresis, or air hunger. You can see narrow loop with figure 8. Now we finish with the pressure volume loop. Now look at the flow curve. It's very helpful to look at the flow curve. With just one quick look will give you an idea if the inspiration and also expiration, both of them are adequate or not. So here you can see the expiration does not end to the 0. And there is an area here, which is the infant unable to exhale all the air out. So you have air trapping or auto PEEP. So you need to be sure that the expiratory limb is reaching the 0 before beginning of the next cycle. The same as you can see here. It could be the opposite. You may have inadequate inspiratory time, which might induce atelectasis, inadequate eye time. So here you can see the infant during inspiration, the curve does not reach the bottom, and expiration start abruptly before reaching the bottom. So you need also to avoid that. And you can see even in the pressure mode ventilation, the PIB does not reach to the top. In hybrid mode, the tidal volume does not actually reach the preset tidal volume. So simply you need to extend the eye time in this case. You need to see the eye time is enough for the inspiratory flow to reach 0 before beginning of expiration. And either the PIP reaching the preset PIP, but we are using now the hybrid mode. You have to be sure that the tidal volume measured is reaching the preset tidal volume. Now let me give you this example. On your machine, assume that this machine is available in most of the units. So you can see now the number here is the tidal volume 6.3. And the number on the screen is 5.8, which is the measured. So you have the preset, this number is fixed, and you have the measured tidal volume, and you have the PIB needed to deliver this tidal volume. So these numbers will help you to understand if this compliance is good or not. So let us see. You can see most of the time, the number is almost either above or matching the preset. So we have a good compliance, and PIB is just low number. And low number in our definition, usually we are using teens, less than 20. Any number less than 20, definitely less than 10 is very low. Or when you have the number equal to PEEP, it means that the machine does not perform anything other than just applying almost endotracheal CPAP. You have room air, infants breathing above the rate is triggering, and you have the loop. Most of the loops are fine, upright. There is no side lie. So this infant is ready for extubation. So to adjust the minute ventilation with high CO2, you have infant with high CO2, and you would like to start initiate tidal volume. So keep in mind that infant with low birth weight, less than 1 kilogram, require higher tidal volume, higher than the infant more than 1 kilogram. The reason for that, there is lost at least 1 ml lost in the dead space. So, for example, you have infant 500 grams. So 6 ml is equal to 3 ml total tidal volume. So you have at least 1 ml lost in the dead space. If you apply 4 per kg, that will be too low. It means that you are applying tidal volume just 1 to 2 ml. For infant more than 1 kilogram, you can start between 4 to 6. And in infant with chronic lung disease, because of significant airway resistance, we are using higher tidal volume and also for compliance. So initial CO2 goal 4 to 60. If you have the CO2 less than 40, then you have to consider extubation. Don't try to wean the tidal volume, as I will explain more later. When you have a improved compliance, you are exposing the infant to air hunger. When you have CO2 higher than 60, then you need to increase the tidal volume or change your ventilation strategy. When you have a change more than 20 millimeter mercury, this is dangerous. It means that you have sudden change in the compliance. So you have to check if there is any pneumothorax or obstruction or anything suddenly happened. And keep in mind, for the first 1 or 2 days of life in premature infant less than 28 weeks, when you have sudden change on CO2, it might induce IVH, because CO2 will also control the brain vasculature. We are using near-field spectroscopy, so we are targeting between 55 to 80 millimeter mercury, because the near-field spectroscopy of the brain will reflect the brain blood flow, which might be affected by significant change in the CO2. Again, you have more than 20% change, then we have to do blood gas and check why there is significant change in the cerebral blood flow. So mechanical ventilation parameters that we are using here, it is either physiologic parameters like tidal volume and inspiratory time or respiratory rate. These are fixed numbers. We are not playing too much with them. We are trying to recruit the lung with PEEP, adjust PIP, just to above the limit that can deliver the tidal volume, and also look at the map as measured value. So in this example here, you have infants ready for extubation and requiring very low pressure. And the tidal volume is even higher than the preset. And let me give you this example here. One of our fellows was on call in the unit for this preterm infant, 24-weeker, 1 week old, failed previous extubation with upper airway tight and on dexamethasone for upper airway. And the blood gas was perfect. It was actually CO2 38, pH 7.38. And you have the tidal volume, the preset 5.5. And he decided to reduce from 5.5 to 5. He doesn't want to extubate at this time. So do you think, is this a correct intervention? Definitely not. You can see that the infant is actually trying to get much higher tidal volume than measured, much higher than the preset. And the infant is breathing very fast. Why? Because the infant is at air hunger. You can see the 8 figure here. He's at air hunger, and that's why he's breathing fast to compensate for the machine trying to bring this number low again and requiring very low PIP. This infant should be extubated as soon as possible. Otherwise, he will develop air hunger. If I am able to extubate before getting the steroid or so, at least I have to increase the tidal volume to lower the rate to get this infant with reasonable physiologic minute ventilation. He's trying to compensate again for low tidal volume by breathing fast to match a physiologic minute ventilation. So decreasing tidal volume means that you are exposing the infant to air hunger as you are strangulating him from breathing. I hope that makes sense. That's probably one of the most important lessons in this presentation. That's very common to happen when you are in the on-call room and the RT is telling you all the blood gases, which is low CO2, And the first thing to suggest to reduce the tidal volume if you are not extubating, which is totally wrong in this case. The compliance is very good, and you did not look at the measured tidal volume. You see how this infant is trying to achieve. So we have two phenotypes of lung compliance. Just compare the measured tidal volume to the preset tidal volume. If it is around 1 and BIB is low, you have a fair lung compliance or very good. If you have the measured tidal volume more than the preset, they will definitely have good compliance, and you need to extubate as soon as possible. But if you have the measured tidal volume less than the preset, then you have a poor lung compliance, and you may need to optimize other things, either eye time or PEEP, to improve the lung inflation. The strategies that we are using in chronic lung disease, when you have severe chronic lung disease with areas with normal compliance, normal resistance, but you have other areas with low compliance and high resistance, other areas with high compliance and low resistance. So you have severe heterogeneity of the lung. AC in this case is not really appropriate. You are using SIMV or high tidal volume protocol. And we are using high PEEP, like 8 to 12, relatively high. In this case, when you see the lung even hyperinflated in the X-ray, doesn't mean that you have to reduce the PEEP. You have high resistance. You need to increase the PEEP to open the airways more. And rate, don't apply rate higher than 25, highest as 30. And we adjust BIB on unsupported breaths, maximum 30, and tidal volume 6 to 8. Sometimes you are reaching 10 to 12 in severe cases. Eye time 0.4 to 0.6. I will just jump to the extubation criteria. Once we have mean air pressure less than 12, BIP to deliver tidal volume less than 20, FI2 less than 0.4, CO2 less than 65, and the infant's triggering the ventilation, and there is some leak to be sure that there is no tight airway, then go ahead and extubate. You may need to give 1 or 2 doses of steroid to relieve edema if the infant intubated for a long time. If the infant not fulfilling the criteria and you need to give steroids, we are using DART protocol as early as 8 days of life. There is wrong concept that you should wait long time. That is not a condition anymore. You avoid DART only during the first 7 days. Beyond 7 days, we can start use it, or typically from the second week of life for infant less than 28 weeks. What we do, we check the chronic lung disease, and there is a lot of AI calculators can let you know the severity of chronic lung disease. And then we check the lung compliance on the ventilator and also by lung ultrasound. And that's actually validated in literature. We have lung ultrasound score more than 10 or worsening, we consider the DART protocol. And if the infant received the DART and still requiring high ventilation, we consider higher dose, higher than DART, as dexamethasone. Again, if the infant was low score and the compliance is good, and you cannot extubate, it could be central drive, so you need to optimize caffeine or upper airway issue, or you need to check TN echo for pulmonary hypertension if you have TN echo surface or by cardiology. Here, you just explain the lung ultrasound is how it is dynamic here. You can see the infant during expiration, the lung collapses and white out. In inspiration, you can see A lines and lung partially open. It means that you need to increase PEEP for this infant. So both lungs right and left, lung collapses at the end of expiration, and the infant is breathing, trying to open the lung in inspiration. So the lung prevention bundle here, it is steroids, intrapartum antibiotics for rupture of membrane, prolonged rupture of membrane, prophylactic nasal CPAP, avoid bagging with high pressure, use blended oxygen, not 100% oxygen, and then for the first 24 hours, early rescue surfactant by mist, non-invasive mist, early caffeine, careful attention to optimize PEEP, and then if intubation needed, use AC volume guarantee, short eye time, and short eye time we are using either 0.3, 0.35, and permissive hypercapnia up to 60. CO2 is okay. Early extubation as soon as the infant is breathing and fulfilling the criteria for extubation. And early rescue, high frequency ventilation of the infants really was worsening lung disease. So precision-based selection of mode, borderline variability 22 to 23 weeks. First intention, high frequency ventilation, and we are using high frequency jet ventilation in North America. So we're not using conventional for 22, 23 weeks as the first intention. And usually keeping them on high frequency for almost 4 weeks. Preterm 24 to 26, you can consider NIV or non-invasive high-frequency ventilation if breathing. But if the infant is apneic, shift to mechanical ventilation, invasive. Preterm 27 to 32 weeks, usually the tolerate CPAP nicely, and then if failed, you can try non-invasive ventilation. Preterm more than 32 weeks, you don't have to consider other than just CPAP, unless the infant require ventilation for meconium aspiration or for pneumonia or for other reason. So the 6 common mistakes that we talked about: weaning volume to be low before extubation. So don't decrease tidal volume with improved compliance. And then after surfactant or DART, because even with DART, you may expect improved compliance. So don't wean tidal volume for that reason. Wean to very low PEEP before extubation, also wrong. Extubate infant with low CO2 immediately because the infant will not breathe. And for that, simply what we do, just apply endotracheal CPAP for just 2 minutes, and that will enough to build up the CO2 so the infant can breathe after extubation. Also, it is wrong to delay extubation and considering low birth weight as excuse. It changes suboptimal nursing. So when you extubate a very premature infant, we maintain 1-to-1 ratio nurse to patient at least the first 3 days after extubation. So the infant on CPAP even require more attention more than the infant on mechanical ventilation. Set low tidal volume in severe chronic lung disease, and to consider HIT or high tidal volume protocol in severe cases. So regarding, I prepared some questions, but already the Dr. Adnan already discussed beautiful questions. Just I have this comment at the end. Don't be hesitant about extubation. Don't think too much. And when you think about extubate and think. I'm just joking with you, but for sure you have to think, but don't think too much and don't be hesitant if the infant fulfilling the criteria for extubation. I hope we have some time for questions.
شكرا جزيلا دكتور ياسر، حياكم الله. شكرا جزيلا، يعطيك العافية، الله يجزاك خير. We can start question by raising the hand, or you can open the mics, or you can write on the chat. It's up to you. وبالعادة بيكون الوقت متأخر فبكون عدد أسئلة قليل.
أيوة،
I
مفيش
don't know
مشكلة.
if you have any question or نعطي وقت.
Until you have a question, probably I will just show you one thing on as AI calculator for tidal volume online.
Okay.
If you allow me, quickly I can show you that. Can you see the website?
Yeah, it's neonatal and pediatric interactive course.
Okay, so if you go to the app here, it is free. So you don't have to pay anything, just you need to sign up. And you go to app, you have a lot of AI calculators that can help you in decision making. And one of them here is for volume targeted ventilation, just to help you to decide how to troubleshooting tidal volume in certain cases. And here we'll ask you a very simple question at the beginning: if the infant less than 32 or more than 32 weeks, and then will be followed by more questions. Just you can see here, when I select less than 700 grams, give me a tidal volume between 5.5 to 6. When you select more than 700 grams, will give you less tidal volume. So when your infant is smaller, require a higher tidal volume. And then we'll ask you more questions about what's the problem encountered during the tidal volume ventilation. I will select here Set tidal volume achieved but inadequate ventilation, like high CO2, and then we'll start to ask you more questions, one by after the other, until you reach the question, the answer that you need. So I said, is a set tidal volume too high? The set that you set yourself compared to the measured, you can say no. And then if the measured tidal volume overestimating the true or preset tidal volume, I can maybe select no. And then give you a suggestion here, consider other reasons for poor ventilation, including lung recruitment. So we may ask you to increase the PEEP. So this I calculator based on all of these published guidelines by the world expert in ventilation, including Dr. Kessler, Dr. Abman, and others. So that's available together with so many other applications that you can use for blood pressure centile values in premature infant, HIE to decide for cooling, and also to manage hypoxemia in severe cases. I encourage you to use all of these AI. They are available for free. You can use any one of them at any time.
شكرا جزيلا دكتور ياسر. في البروف عبد الرحمن النمري أعتقد في
شكرا يا
استفسار.
عدنان. أنا was waiting for the new generation to start the question لكن ما حد يبغى يرفع. حياك الله بروف ياسر، مشتاق لك.
اهلا وسهلا بيك دكتور حبيبي دكتور عبد الرحمن.
الله يحفظ
وانا والله
إياك.
يعني مشتاقين نشوفك.
دائما منورنا، أنار
فرصة.
الله قلبك وزادك علما وحكمة ورشدا. السؤال اللي دائما بيطرح نفسه بروف ياسر، النيو جنريشن والجنريشن جاب. اتذكر في التسعينات كنا عندنا what we call it beep phobia. We never go above 4. يعني if you go more than 5 you look for pneumothorax. Is there any clear guidelines for each gestational age, certain beep that I cannot exceed it or I have to put it؟ لانه لا زال الفاريشن هذه موجوده في الجاب. تلاقي بعض الاولد، انا مش منهم طبعا، انا يانج we are in the new generation. لكن still if you start to use high peep, which I love it, I like it, next day he's on surface, he'll cut it down to 5 or to 6. How we can adjust this? If you have, do we have any clear evidence to choose which peep for each gestational age?
Wonderful question. You know, at any conference, Professor Abdurrahman, I usually wait for your smart questions. And really, I pay attention and mind to understand exactly the question and be careful about the answer.
تسلم حبيبي، تسلم.
أهلا وسهلا بيك.
تعلم منكم دائما.
أهلا وسهلا بك، ربنا يكرمك Professor Abdurrahman. I really enjoy your smart question. So definitely, I think this part was not really clarified well in the presentation, and that's very important question. So there is two different population that we have to be very careful in applying PEEP. The first population, when we have the lung still fresh and very susceptible to develop a pneumothorax, which is sometimes a nightmare to a lot of colleagues. So for the first ventilation initially to start with 7. So 7, it is a number that I was a member in the Canadian Pediatric Society guidelines for use of surfactant based on the ultrasound assessment, and we selected 7 to start with for typical RDS or TTN for premature and term infant. It is a safe number to select, and we never seen any, for example, last few years, pneumothorax. We actually forget about it. When we used to increase to 8 or 9 before giving surfactant, we had to see pneumothorax, and that's before the era of lung ultrasound, because now we do all the ultrasound early, even by our RT, and then they decide for surfactant very early. So there is no chance for the lung compliance to continue worsen over time, and maybe X-ray might mislead if you are lung only in X-ray to decide to give surfactant or not. So that's the first transition. Usually, to start at 7, don't exceed 8 at the beginning. There is some very kind of stable infants with TTN. You can use even 6 on them if the TTN is really mild on room air. But we're talking about infants with respiratory distress, tachypnea, grunting. You are using 7 as a standard number. If the infant with very poor bad lung, like meconium aspiration, like beyond the TTN and RDS, and you need to escalate beyond the 8, we usually shift to high frequency for more gentle ventilation. And we are using, as you know, jet ventilation in North America, which is more gentle to recruit the lung. If the infant is beyond RDS, we're talking about meconium aspiration or very bad lung or hypoplastic lung. So if we need higher than that, we shift to gentle mode of ventilation, like beyond conventional, like jet ventilation, or if you don't have it, high frequency oscillator might work as well. Now, if we move beyond the transition, we are talking about severe chronic lung disease. Now the lung is very stiff and fibrotic. Even if you apply too much PEEP, the infant will not develop pneumothorax. I haven't seen pneumothorax for infant 5 weeks old with chronic lung disease on PEEP of 15 or even higher. The complication that might happen, overinflation of the lung, compressing the heart, and affecting the venous return. But pneumothorax, because of the pleura, is very fibrotic and very tough, and also the lung is very fibrotic. It's almost very difficult or impossible to develop pneumothorax. But you may see the infant with compressed heart and with hyperinflation and air trapping before you see pneumothorax, if we assume it might happen. One of the wrong concepts, when you see in the X-ray lung is hyperinflated with air trapping, it might be because of high resistance. Reducing PEEP, in this case, it might actually cause more air trapping. You need to open the airways. And the judge on that, we do what's called the PEEP study or PEEP escalation, guided by a table. When you escalate the PEEP stepwise, you record how much FiO2 is needed and how much saturation improved. If you have lung ultrasound, we do lung ultrasound in between. If you don't have lung ultrasound, clinical assessment based on the saturation in FiO2. If you see the saturation improved and the FiO2 decrease, you are in the right direction. You are recruiting the lung. If you are in the direction of hyperinflation, you should see the opposite. I hope that I answered your question.
Till now, there is no clear guidelines for each gestational age. That I agree on, and this is a good comment from the fresh, different from somebody who started to develop some fibrosis. Like not a clear guideline that's smaller. Nowadays, we are stating 24, 25, 23 weeks. Do you still apply high PEEP for such extreme low birth weight infants?
Yeah, the only exception that we are using a specific protocol, again, that's a very smart question. Very specific protocol for 22, 23 weeks. We start at 5. And
Okay.
we have now a protocol share, like we are applying similar protocol to the centers with dealing with the small babies, like tiny 22, 23 weeks, like Iowa. And there is a published guidelines on that. We are using to start at 5 for them. Sometimes even we go lower, like 4, only for 22 and the 23 weeks. And we start as first intention jet ventilation. We don't start a conventional ventilation for them. For 24 and beyond, probably minimum that we use before 6, but usually 7 is the standard. Less than that, probably is like the lung is really stiff. It's difficult to recruit the lung with less PEEP than that number. If you're applying non-invasive ventilation, we are not using CPAP for very premature babies. You are using either non-invasive NIV or nasal high frequency for those less than 27 weeks after extubation. And for that, you apply not PEEP, you apply minimal pressure, which is a little bit higher. And that will help actually to keep the lung recruited. So we concerned about the numbers during transition based on the underlying gestational age, but beyond the transition and chronic lung disease, there is no limits. As I mentioned before, the limit is to recruit the lung to FRC, regardless what the number you are applying. And
Okay.
I have before 15, 17, 20 in rare cases, but usually in most of the chronic, moderate to severe chronic lung disease, anything between 10 to 15 usually needed before steroids. Once you start steroids, you should be able to wean the PEEP or mean wear pressure down to 10 or even single digit. for extubation.
عدنان لو ما في أسئلة أنا عندي another question لو if you allow me.
كثير بروف، ما ادري اذا تسمح لنا او لانه صار في عبد الله رافع، ممكن نعطيك فرصه بعد نسكت الشباب.
طيب خلاص once you get a gap let me
عبد الله ما ادري اذا حابب يحكي.
ايوه
تفضل.
شكرا دكتور عدنان for organizing this. So thank you very much Dr. Yasser for this excellent basic for ventilation. My question regarding FI2 requirement, we started to hear sometimes don't worry that much about FI2 if it's sitting on 30s or 40s when you think that you are optimizing everything else in terms of the ventilation and you have your graphs and everything. Is this 30 to 40 when sometimes we try our best to draw but we cannot still be affecting on the long term, providing saturation 90 to 95, or no, still harmful?
Yeah, definitely in oxygen more than room air, there is harmful effect, but definitely if you are exceeding the number that we usually try to avoid more than 50%. Why? In the literature and in physiology and even animal studies, they found that more than 50% FI2 will induce pulmonary vasoconstriction. Like you may induce pulmonary hypertension over time when you apply FI2 more than 50% for a long time. So less than 40% is probably acceptable in chronic lung disease. And even we extubate, as I mentioned, like criteria for extubation, less than 40% is still okay. More than 50%, you have a big issue with the VQ mismatch, and you need to work to optimize everything else to get the FI2 down. So the FI2 more than 50% is unacceptable, and you need to do everything you can to get the FI2 down, either by recruiting the lung more, you may need to treat any VAP assumed pneumonia, or you may need to give steroids sometimes to improve the ventilation perfusion mismatch and they get the toxic effect of the FI2 down. Just one more comment about the target saturation. We're not using 90 to 95 fixed to everyone anymore. We are using based on the physiologic stage, and that's actually being applied now most of the centers in Canada. So for very premature infant during before the corrected age of 32 weeks, we are using 88 to 92. Excluding during the first 3 days during transition, we are using 89 to 94, a little bit higher. But beyond that, until corrected age of 32 weeks, during the ROP era of development, we are using 88 to 92. And then beyond the 32 weeks, during the BBD development, we are using 90 to 95%. And for corrected age of term, we are using 92 to 96%. So we have a staged target saturation based on the physiologic stage. So 90 to 95, I think it's probably all the concept now in most of the centers, in at least in Canada.
شكرا جزيلا.
صراحة we have a lot of questions على chat. I don't know if we can answer maybe most of them. Do you recommend any source or what the source to recommend for studying mechanical ventilation?
The best source to study mechanical ventilation is your clinical practice and your mentorship. You are working with wonderful colleagues, and your main source to understand the physiology very well to start with, understand your own machine or your technology that you are using, which might be different, and at the same time have a specific agreed on protocol or strategies that you apply to everyone. So not everyone in the unit applying his own concepts. So you should agree as a group on a specific strategy. And from during your fellowship, you have a lot of cases that you are dealing with, and you have to just deal with each case as a pre-session based on the physiology. And then you can read as extra. There is a lot of resources. One of them is a textbook for the mechanical ventilation by Dr. Martin Kessler. Then the new edition is coming soon, and I have that chapter on hemodynamics in that book. So I don't advocate for the book because I'm included in the as one of the authors, but It is one of the very famous books for mechanical ventilation. And don't buy the current version. The next version is still under review, will be up probably within a few months from now. We have also some online courses that we have with very small registration fee on our platform, New Beats Academy. So I have a course together with Dr. Ruben Alvaro on mechanical ventilation is available on our website. So you can use it if you like. I advocate to maybe read as well the American Academy of Pediatrics and the new reviews, written articles on mechanical ventilation.
طيب دكتور ياسر، عدد الأسئلة صار كبير، ما أدري are we going to go over all of them?
It's too late for you, but I'm fine. I have
Okay.
no problem.
Would you kindly explain again clinical impact of C20 over C dynamic from clinical point of view?
Yeah, definitely. So maybe I have to share the slide again, if you don't mind. That might make it more clear. And I need to share the
رح
screen.
نشارك التسجيل معهم إن شاء الله تعالى كمان. It will be more clear إن شاء الله.
Inshallah. Yes, I need to share the screen again. I will explain the concept, and you will get actually the number is ready on the machine. So now you have, can you see the screen?
Yeah, clear. واضحة.
So we have in this y-axis the volume and the x-axis the pressure, and you have the what's called the pressure volume curve. This pressure volume curve, the perfect one is more upright. When you have it more horizontal, it means you have poor compliance. So that's one. Number two, the bottom part here, when you have very flat side lying, it means that you also have poor compliance. When you it means that you have a long time between your preset PEEP and the infant start to breathe. So you need to move your PEEP higher. Next, one of the most important interventions, when you apply the axis of the main curve here from the beginning to the end, and another axis here to the top part, the last 20%. So that the peak or the last 20% apply another axis here. You have an angle in between. This angle will be calculated by the machine. So when the both lines are identical, it means that you don't have angle, you are very good, and the compliance at the last 20% of the cycle is exactly the same like the entire cycle. But if the angle is more flat for the last 20%, because the infant is more struggling with the compliance, I mean more flat compliance at the last 20% of the cycle, it means that you have over distension. So the infant at the end of inspiration is getting air trapped, and the compliance is poor. That's why it's more flat, the last 20%. And you have angle in between is wider. So when the angle is wider, you have the number less than 1. If this is than 0.8, C20 over C, it means that you have air trapping. So you need to either decrease the tidal volume or decrease the PEEP to reduce air trapping. You have this number actually on the machine, C20 over C. If you are using the rigger, even old-fashioned rigger, they have the number. You have to just to click on the machine to get the page that give you the C20 over C. If you have 1 or more than 1, it's perfect. More than 8 is 0.8 is acceptable. Less than 0.8 is a sign of over distension. Is it clear now? I hope so.
I think. Next question, could you please explain what's meant by air hunger and how to manage?
Another very good question, and very important as well. Let me show you on the screen. When you go to the screen, let me show you an infant with air hunger. You go to the screen. So when at any time you would like to change anything on the ventilator, or you have a plug gas, don't rush and change setting based on the plug gas when the RT discuss the result with you. You have to go to the screen and you have to check all of these numbers. So you have the preset tidal volume that you guys are already preset. But more important, you need to check how the patient reacting to that. If the patient trying to get a higher measured tidal volume, it means that the patient's trying to breathe higher because of good compliance. But at each time he's trying to breathe higher, the machine trying to lower the PIB to bring this number down to match the preset. When the machine is trying to do that, because the preset is low, the infant will be at air hunger. So again, when you lower the tidal volume, the preset, but the infant is trying to breathe because of good compliance, breathe higher tidal volume, the machine will try to bring the number down. So you can see the number is high 19, and then the next is lower, down to 6, because the PIB you will see the PIB is getting down. So the machine is trying to tell the patient that I understand you, or my physician understand you better than I understand your physiology better than you. So you need to breathe less, and I will strangulate your tidal volume to be lower, which is really bad. So try to understand the patient, and try to satisfy the patient needs for higher tidal volume, either to just extubate him or increase the tidal volume. And that's why he's trying to breathe fast, because he is, as you are just putting your hand over his neck and not allowing him to breathe comfortably with higher tidal volume. That's why he is trying to breathe fast to compensate and to create higher minute ventilation.
Next question, Yasser. I would like to understand the role of time constant in a clinical setup. يعني بعض الأسئلة ما أعتقد هي يعني
Yeah, that's
كانت
very good question. I actually I did not include that because it's one of the most confusing concept to the fellows is understanding the time constant. Time constant by the machine just evaluate how much time needed to deliver each 30% of the volume down to the lung, and the time needed for that. And this time constant increase in two situations. Once you have high resistance and poor compliance. That's why in situation when you have higher time constant, you need to increase the I time to get more time needed for the tidal volume to be delivered to the lung. And simply you can assess that by looking at the curve. Just go back to the curve here. So once you see the expiration doesn't go back to zero, that could be either because of air trapping or because of higher resistance. So you need to decrease the I time and give more time, or decrease the rate to give more time for expiration. That's one of the applications for time constant. The other application that there is no enough time for inspiration to goes in. So you need to increase the I time to get the all of the volume or all of the pressure needed to match the target. So to judge the time constant easily, you need just to look at the flow curve and be sure that inspiration goes back to zero. You don't have to increase the inspiratory time, and the expiration goes back to zero, so you don't have to reduce the rate, or be sure that there is no auto-triggering. Sometimes the auto-triggering happens because you have too much water in the circuit, and that's auto-triggering, and the patient's breathing fast, and there is not enough time for exhalation, and might cause more air trapping. So the I time is calculated as the first 1/3 of the volume goes in, how much needed to that, and time constant 60%, and so on. So basically just look at the curve, and that will give you enough judge if the time constant is physiologic matching your I time and rate and expiratory time or not.
Okay, شكرا جزيلا. What's the guideline to give surfactant in RDS and mass or pneumonia? إذا في شيء brief ياسر بعد إذنك.
Yeah, maybe I will show our table that we are using in now the the Canadian Pediatric Society, and it is the same table published in the Canadian Pediatric Society guidelines. We are now using lung ultrasound, which I think you are still in the process of getting that established, I assume.
Yeah.
So in any newborn with respiratory distress related to RDS, meconium aspiration, pneumonia, whatever reason, RDS during the first 5 days of life. So we can repeat the surfactant during the acute stage of RDS during the first 120 hours of age. And we are starting a CPAP of 7, as I explained. If the lung ultrasound score 9 or higher than 8, and the FiO2 more than 25%, that's enough to give surfactant. If the infant intubated, if you intubated the infant and the ultrasound score is still showing higher score, we are not using the FiO2 as a condition. You may be room air, because the invasive ventilation might mask the oxygen requirement. Once you exhibit the infant without surfactant, we'll get higher FiO2 and will get deteriorated again. So only FiO2 is a condition if the infant is on non-invasive ventilation. Infant intubated, but the score is consistent with RDS or higher score because of meconium or pneumonia or whatever reason, then give surfactant. And surfactant for infants between 27 to 33 weeks, we give it by mist or LISA. For 33 and higher, they are fighting a lot, and it's not easy to deliver mist. We are using Ensure. So intubate with little bit light sedation and extubate after surfactant. Babies less than 27 weeks, it's difficult actually to use mist on them. And usually when they need surfactants, better to intubate at least until you stabilize them better, less than 27 weeks. What's the surfactant value beyond the first 5 days of life? Again, I have to mention that it's not about just one dose. You may need to give a second dose and the third dose. And once you reach 3 doses and no improvement, you have to investigate for protein B deficiency. So you need to consider my genetic testing for protein B deficiency, especially if there is family history of that beyond the first 3 doses, or it could be severe meconium aspiration. In case of beyond the first 5 days, infant 2 weeks old, can I give surfactant? Yes, you can give it in pneumonia, severe pneumonia with worsening lung condition overall, or with ARDS, acute lung injury, infant with severe bronchopulmonary dysplasia, requiring very high sitting mechanical ventilation, although you are on high frequency. You can say give surfactant, either surfactant mixed with steroids or just surfactant without steroids. And that can improve just temporarily. Surfactant is not a magic. The half-life is only 8 hours. So it is working just for 8 to 12 hours until you get the lung compliance improved by other strategies.
Next question, what is the typical, it's maybe optimal beep when starting CPAP?
What's the optimal PEEP when starting CPAP? You mean to extubate to CPAP?
لا أعتقد when we start maybe from the beginning. That's what I understand.
Yeah, like 7, we are using 7. That's a number that we are considering for RDS. For TTN, it's okay to, if the infant is just mild tachypneic and confirm TTN either by X-ray or ultrasound, you can use 5 or 6. But for typical RDS, 7. We are using 7. And don't wait long time before you give surfactant. Because if you escalate without giving surfactant, especially in late preterm and term infant, they are easy to develop pneumothorax because they have more lung compliance, but the chest wall is more tight. For late preterm and term infants, it's easier for them to develop pneumothorax. So we're using 7, 8 at the maximum before you give surfactant. If you need to escalate higher, 9 or like in severe cases, then consider beyond CMV, like oscillator or high frequency ventilation mode.
And next question, could you please explain why SIMV is the mode preferred for BPD management?
Wonderful question. Okay. Let me explain a little bit more based on the slide. Let me close this one. And let me share the screen again. Okay, can you see the slides again?
Yeah, واضح.
Okay. So the protocol that we are using is called the head protocol. We need actually as like a separate presentation to talk about a strategy of ventilation in chronic lung disease in general. So first, we need to understand in severe heterogeneous chronic lung disease, the lung is totally heterogeneous. You have areas with high resistance, other areas with high resistance and poor compliance, and areas with good like normal resistance but high or poor compliance. So significant heterogeneous. So the strategy for that, you need to give enough tidal volume. And to give enough tidal volume, high tidal volume, you cannot give it in a rate of 40 or 50. So you have to give it in a low rate. And we are talking about 20 to 25. In this strategy, we are using a rate of 20 to 25. And the rest of the cycles, they are unsupported. It means that the preset tidal volume, which is really high, talking about 6 to 8 up to 10, sometimes up to 12 in severe cases, you cannot give it on a rate of 40 or rate of 60. Yeah, because you need enough eye time for that. And enough eye time, I'm talking about 0.4 to 0.6. And again, you cannot give this long eye time when you have rate of 40 or 60. So you need to limit the rate to 20 to 25. And you can do that only on SIMV. Because as I explained before, SIMV only supporting whatever rate that you preset on the ventilator. The other presses will not be supported. So the other presses, or the infant will be breathing his own tidal volume, which might be very small based on his own compliance. And this big tidal volume will be delivered with this long eye time only for this 20 to 25 breaths. So if you apply AC plus VG and the infant is breathing 40, then it will be, the infant will develop significantly air trapping because you don't have enough time for exhalation because of this long eye time with this big tidal volume. Make sense?
Yes.
Next question can Dr. Sagar I'm wondering, the clinical assessment is not from extubation criteria. Even patient has subcostal retraction, for example.
The
Yeah,
clinical, assuming that if the infant is on mechanical ventilation and compliance is good enough, you should not see significant intercostal retraction. If you see the retraction on the infant mechanical ventilation, then definitely you will see the infant requiring higher PIP, higher than 20, unable to deliver the preset tidal volume. You will see the measured tidal volume less than the preset, and you will see definitely higher oxygen and higher CO2. And that could be like evident also in the graphs. You will see the sideline graph. So it means that the compliance is poor. I can't assume that the infant compliance is good enough to extubate and is still working hard to breathe. Make sense?
Yeah, I think what's your recommendation regarding use SIMV plus Russia support? I think maybe this is the last question.
Yes. So here in this mode, we are using the typically what you said. It is SIMV, and we are using pressure support of 6, sometimes up to 10, just to support the non-supported breaths. So we have two types of breaths here. Let me go back to the graph of A sine V. So we have two types of breaths. So we have supported breaths and unsupported breaths. So for supported breaths, you give the big tidal volume and I time is long, and you have in between unsupported breaths. So you apply pressure support of between 6 to 10 pip without volume, that's just the pressure, just to support this unsupported breaths with the tidal volume, preset tidal volume. So both actually will be supported, but not at the same level of support. So the big breaths, the 20 or 25, will be supported with long I time and big tidal volume and enough expiratory time. In between, you have small breaths, only supported with little bit tiny pressure, like 6 to 10. And that's very good question that you asked this question. So it is hybrid actually with pressure support.
شكرا جزيلا دكتور ياسر. ما ادري اذا البروف النمري كان في عنده تعليق او سؤال سابق.
انا شاكر جدا، ما شاء الله تبارك الله، ليله ممتعه. بس الكونسيبت في كثير من الوحدات بروف ياسر، انه الاس اي بي في والاس اي بي في يعني they used to start with the access control and then they will not extubate him until they move him to the mode of SIMV because they have the concept this is the mode of extubation, then you extubate. I'm trying my best to convince them they can extubate from SS control when you are in this criteria of the map. Still, they're insisting they have to put him to SIMV. Sometimes the SIMV with the pressure support is okay to take care of that non-supported breath. But if you use SIMV alone for quite long time with a shorter rate, you are not afraid that he will develop some atelectatic changes because most of this non-supported is not enough at times, especially for extreme low birth weight. الكونسيبت الثاني الهاي frequency. When you start to have a baby who cannot be oxygenated and you want to shift him to high frequency, some people they may wait until his MAP reach to 14, more than 12. Although they know that the baby from the beginning has a problem of oxygenation, maybe a degree of BPHN, maybe some other pathology. Hesitant to shift him to high frequency is another misconcept in many units in Saudi Arabia. I need your comments, Prof.
Yeah, like wonderful comments and the questions, Professor Nemri, and I really always enjoy your comments. So regarding the first one, so about 5 years ago, we used to shift to BSV, not SIMV, BSV, for about 30 minutes before extubation. It's even more disaster, more than SIMV. And we, fortunately, we stopped using this concept and we extubate definitely from AC. I'm talking about extubation of premature infant. Term infant doesn't matter. Talking about premature infant with very limited capacity to create I time. So when you allow the infant to breathe and create his own I time and rely on his own breaths through a PSV, may get tired very easily, as you are allowing him to breathe for very narrow tube and get tired. So that might help actually in failure, his failure, post-extubation failure. So we stopped using that. What we do sometimes, just we reduce the rate. Be sure that the infant's triggering, okay. If we reduce the rate to 30 or 40 is still breathing above, and that's enough. Infant's triggering and breathing above the preset rate is enough that the infant might continue to breathe after extubation. And again, we are using not only CPAP, we are using non-invasive ventilation or nasal high frequency, or in some centers now we are using NIV-NAVA in extreme premature babies. So the same concept in SIMV, because SIMV only it is valuable in premature babies when you give enough tidal volume with enough I time in severe chronic lung disease. That's the main value physiologically published and validated. But if you give SIMV in the same tidal volume that you are using in AC and the same I time, definitely it is the same same issue that might happen in BSV. You're allowing the infant to breathe by himself with unsupported breaths and will fail. And that might actually, it might be the reason why the infant might not tolerate post-extubation breathing adequately and post-extubation lung recruitment. So that's not really physiologic thing to do, especially if you do it for a long time. If you do it for more than 10 minutes or 15 minutes, that definitely the infant will get tired. So I don't advocate for sure to do that. Just extubate from AC. The maximum that you can do is just try lower rate to be sure that the infant is breathing above, and that's enough. Regarding the infant with very poor lung compliance and heterogeneous lung, meconium aspiration, or any type of other lung disease like diaphragmatic hernia or whatever type, when you apply during transition too much PEEP trying to recruit the lung, and also when you have a ventilation issue, don't wait too much time, because you may damage the lung more, and you have to consider a more gentle strategy to keep the lung recruited. Especially in premature babies with very bad lung, we are very like early considering jet ventilation at early stages, once we have the infant requiring higher PIP to maintain the tidal volume. So you don't have any hesitancy to shift immediately to jet ventilation. Again, by intention, we are using jet ventilation as a first mode in 22 to 23 weeks, and for the first few weeks of life. I don't think we just shift to conventional only if the infant is washing CO2 and requiring very low PIP or low mean air pressure, and the jet ventilation or high frequency ventilation does not work anymore. So in this situation, we may shift, but as long as the infant is maintaining normal CO2, we just give more time for the lung to grow, and give more chance for the compliance to improve before extubation to non-invasive ventilation.
شكرا جزيلا يا ياسر، احنا تعبناك وتعبنا حبالك الصوتية الليلة، لكن تحملنا. الله يحفظك.
I enjoyed very much the
كل عام
questions.
كل عام وانت طيب، والشكر موصول للدكتور عدنان ودينامو هذه المحاضرات. جزاكم الله خير. شكرا جزيلا.
We plan 40 minutes تقريبا. It's about 2 hours now يعني. الله
we enjoy it. أنا بسمي الدكتور ياسر صلاح النيوتولوجي، محمد صلاح الكرة، وأنا محمد صلاح النيوتولوجي، لأن كل مرة نتعلم حاجة كل مرة نتعلم حاجة جديدة ونشوف شيء جديد من علمي. الله يحفظه. شكرا جزيلا.
اهلا وسهلا بكم، كل عام وانتم بخير جميعا.
مستقبلا ان شاء الله تعالى. شكرا جزيلا. يعطيك
اشوفكم قريبا باذن الله جميعا.
حياك الله.